Good evening, everyone. Today, we are going to have another webinar of our Advanced Diagnostic Skills Forum of Sri Lanka College of Internal Medicine. So, I invite Dr. Krishanda Jayasegara, President, Sri Lanka College of Internal Medicine, to address the gathering.
Thank you very much, Sudarshan. I think the Advanced Diagnostic Forum of Sri Lanka College of Internal Medicine was initiated last year to actually to educate our interns, the internists, the trainees on the latest advances in the diagnostics, which are important for their the clinical decision making. Of course, the virology has expanded actually since the COVID was the eye-opener for many clinicians, where we learned a lot on virology. Post-COVID, there was a exponential expansion of diagnostics, which has helped immensely to for us to achieve clinical diagnosis. So I think today we are going to talk on evolving landscape of virological diagnostics, and I'm really thankful to Dr. Rohitha Muthugala, consultant medical virologist, Medical Research Institute, and for accepting our invitation. And I'm pretty sure the trainees, the internists, and all the medical officers who are joining today will immensely benefit from today's talk on evolving landscape of biological diagnostics. Over to you, Sudarshan, to introduce the speaker and proceed with the webinar.
Thank you, Dr. Krishana Jayasegara. As already Dr. Krishanda Jayasegara introduced our speaker, Dr. Rohitha Muthugala, is a clinical virologist, consultant virologist in the Medical Research Institute. And then he's going to speak on evolving trend in this landscape of virological diagnostic. So before starting the lecture, few housekeeping comments. So please keep your mobiles switched off, and then when you have questions, please type in the Q&A section of the questions, and then your questions will be answered at the end of the lecture. And towards the end of the lecture, there will be a QR code displayed. Please scan the QR code and enter your details to obtain the CPD certificate. So if you have any issues, please again type in the Q&A session, and we will able to assist you. So again, back to our session. So Dr. Muthugala, over to you.
Good evening, everyone. Thank you for inviting me for this lecture. Today, I'm going to discuss a little bit about the virological diagnostics and how to utilize those diagnostic facilities for you all to come into a conclusion for a proper diagnosis. So just to basic introduction first, the viruses, we all know viruses are obligatory intracellular parasites. So they can infect all type of life forms, including animals, plants, other microbes like bacteria and fungi. But the important thing is these viruses only replicate inside the living cells. So it do not multiply outside living environment, and they use the host cells mechanism to replicate. And viruses are considered as a commonest infectious agent to infect humans. So in human infections, more than 90% of the human infections are responsible for the viruses. These viruses can account for wide range of infections like respiratory tract infections, febrile illnesses, gastroenteritis, then exanthems, congenital infections, ocular infections, encephalitis and meningitis, hemorrhagic fevers, and sexual transmitted disease, and more other things. Also, some viruses are associated with cancers. For complicating these viral infections, some viruses can cause different type of these clinical syndromes. And sometimes this clinical syndrome can be caused by different viruses. So, coming to a proper diagnosis is very complicated. And viral infections can be sometimes present as outbreaks, maybe it lead into epidemics, and as you experience, it can lead into pandemics as well. Also, some viral pathogens are exclusively human pathogens, but sometimes it can be acquired from animal sources. We call those are zoonotic infections. So coming to diagnosis, to get a proper diagnosis, we have to understanding what about this natural history of viral infections. In humans, there are three types of main category of viral infection. One is acute infections, then chronic infections, and some viruses can cause latent infection, which they can reactivate when human immune system get compromised. Also, these viral infections lead from asymptomatic infection to sometimes mild infection, then lead into a life-threatening serious infections. Also, virus infection sometimes localized into one anatomical site, or sometimes virus can go into our circulation and present in the blood, we can call viremia. Because this basic understanding is very important to come into a collection of proper sample and requesting a proper investigation to the laboratory to get correct results. Coming into acute viral infection, the dengue, primary dengue is a good example. So in acute viral infections, as you can see, once patient is feel the infection, after incubation period, the virus will be remaining on the body or infected site up to 4 to 7 days. Then around day 4-5, IgM antibodies, which is the antibody of acute response, will occur, and its peak around day 6 and 7. And importantly, these IgM antibodies can last up to 50 to 60 days. That is very important. Then IgG antibodies usually appear around day 5-6. Its peak around day 10-14. And most often, these IgG antibodies will last lifelong. So if you going to in acute stage, the early phase of the infection, you have to look for viral targets. Then late phase of the infection, you have to look for a immune response target, whether IgM and IgG antibodies. The other thing is, the things complicating these IgM antibodies may be present up to 50 to 60 days following acute infection. It is very important to understand, because if you test these IgM antibodies maybe after 2 to 3 months even, you can detect it. That is why these serological assays, we have to interpret very carefully. So dengue, chikungunya, maybe influenza, those are very classical examples for these acute viral infections. Then coming into chronic viral infections like hepatitis B, HIV, hepatitis C, the thing is, virus will remain in the body for a long time. Same way, total antibodies will remain, usually peak in 1 month, and it will remain. So during any time, these chronic viral infections, antibodies, and even in the virus, both can be detected in the human blood. So it is very important to understand this type of chronic viral infections. Presence of antibodies may nearly not the confirmatory diagnosis. You have to go for a viral targets in this situation. The third type of viral infection is the latent infection and reactivation. Classical examples are cytomegalovirus, Epstein-Barr virus. We get the viral infection in our childhood, and there will be virus in the body, the viremia. Then after acute phase, this virus is hidden in our cells, especially in our white blood cells, and its low level is detected and it's remain in the body. Once the patient get immunosuppressed, like renal transplant or starting biologics, cancer therapy or HIV, there's no immune support is less, then the virus get reactivated. So that will be a reactivation. So during this phase, the quantification is very important because this asymptomatic multiplication might be there in the late phase, but in immunocompromised state, virus when cause the disease, there will be high viral load. And the same time, after primary infection, antibodies will be present at any time. So these three patterns is very important to select what is the test and investigation you are going to do with these viral infections. So for diagnosis of viral infections, we have two broad methods. One is we call direct methods. We're completely looking for a viral targets. That's by virus isolation or directly looking for virus by electron microscopy, or we detect the component of the virus like virus antigen or virus genome. These direct methods are more specific. So if you detect this one, by direct methods, it's give direct evidence of the virus is present in the human body. The other method is we are going is indirect methods. We are looking for specific immune response against the viruses by detecting specific IgM or IgG antibodies against that virus infection. The problem is indirect methods. Indirect methods sensitivity may be high, but the specificity might be problem because sometimes after infection also there might be IgM antibodies might remain. Also, there may be cross-reacting among close related viruses as well. So virus isolation is a gold standard test, but this is not routinely used for diagnostic purposes. This is only used for reference and research work, but this is the confirmatory, highly sensitive method. If you isolate the virus from the human tissue or blood, you can prove it, this infection is there. At the moment, we are using this test only for acute flaccid paralysis surveillance, that is due to polioviral infection surveillance, as plus as enterovirus. And sometimes we use this one for rabies virus diagnosis as well. But this is not applicable routinely for other viral infections because this will take some time and need specialized cell culture facilities and specialized laboratories for this purpose. Then sometimes we can visualize these viruses by electron microscopy or by histology methods, like seeing this typical owl-eye appearance in tissue samples in cytomegalovirus infection or rabies Negro bodies like thing. But the problem is the sensitivity of these assays are less, and you need electron microscope facilities at every place. So this is not routinely practical as a diagnostics test. Then come into viral antigen detection. There we try to look for specific viral antigens in our human samples. So we can detect any component of the virus. These are protein structures. So we have to collect the sample from the viremic phase and from the infected site. So even tissue samples can be detected. We use different techniques like ELISAs, immunofluorescence assays, immunochromatographic rapid test. So these tests can be used as a batch test, or maybe sometimes can be used as a random access test. And these are highly specific because we are looking for viral antigen part of the virus. So it will confirm the viral infection present in the human body. But for this thing, need high concentration of viral antigens in the sample. And usually these tests are target oriented, like examples like dengue NS1 antigen, hepatitis B surface antigen, HIV P24 antigen, and hepatitis C antigen as well. Then the most popular test now these days is detection of viral DNA or RNA, the viral genome, by molecular methods. The common method is we are using is now real-time PCR, which is highly sensitive, highly specific, and sometimes we can quantify the viral load. It is very important in certain disease management like HIV, hepatitis B, cytomegalovirus, hepatitis C virus. But the thing is, for genomic detection, we have to get the sample from the infected site during viremic phase. So late phase, if you collect the sample, then these tests will give false negative results. Usually these PCRs are run as a batch test. You have to collect the samples and run as a one go. We have to put positive and negative controls and as a batch test. And we need specialized laboratories and trained staff for this one. The problem is these molecule assays are expensive, but nowadays point of care rapid PCR test also available, now available in Sri Lanka as well, especially in private sector. You can put one sample and do the PCR test and get the report within 3 to 4 hours. But these tests are usually target-oriented. Sometimes unexpected or unknown pathogen detection might be a problem in these kind of assays. Then just to add a little bit of after COVID, I think everyone was wondered what is this CT value. It is indicator of a viral load. If it is CT value is less, that indicates the high number of viral particles in the initial sample. If it is CT value is high, that means less number of viruses in the initial sample. So this can be used as a guide for where the patient is in, because if it is higher viral load, maybe patient in the early phase of the infection. If it is viral load is less, patient might be in a late phase of the infection. But the accurate value is comes in a quantification assay if it is doing the fluid like blood or urine. But the problem is it may be not a good indicator for surface samples like respiratory samples or wound swabs or something like that. Sometimes the surface samples, the containing viral is, you can't calculate exactly is it quantify this one. So sometimes this may not be very applicable for respiratory viral infections as well as some other surface samples as well. But during COVID, we use this as a guide, but for respiratory samples, it is not a very suitable thing. As a blood or urine, it's not taking from a directly like a concentrate, giving a concentration. Then other thing is we going for detect the immune response of our immune response as an indirect evidence of viral infections. Usually we do this by detection of antibodies, specific antibodies against certain viruses. So there are different type of techniques are available like ELISAs, then the immune fluorescence assays, and sometimes these rapid immunochromatographic tests. So these tests will perform as a batch test or sometimes as an individual test. The thing is sensitivity is very high, these infections, but specificity is less because there will be presence of antibodies, IgM antibodies for long time after infection. Also, there may be cross-reaction among antibodies in closely related viruses. So, this antibody testing can be used for diagnosis of acute infection or detection of past exposure or immunity against certain viruses. So, if you need to go for antibody testings, you have to collect the samples from late phase of the infection. If you collect the sample from the early phase of the infection, there will not be antibody response in the human body, so you can't detect specific antibodies. So timing is very important. The other thing is for IgM detection, usually this IgM appears after day 5 of the illness, and it gives only the evidence of recent infection because IgM may be last for 3 to 4 months following infection. Like example, if you get a dengue asymptomatic infections 1 month ago, and patient present this time with another febrile illness, if you test for dengue IgM, they might be present. That's why this antibody testings has to be correlated with other clinical findings. And IgG antibody detection gives evidence of past exposure or vaccination. It's usually single test, is not a confirmatory test, but if you can show fourfold rise or decrease between two samples 10 to 14 days apart, you can confirm this infection is due to that specific viral infection. But if it is single IgG positivity, gives only the evidence of past exposure or evidence of vaccination against that virus. But in chronic viral or latent viral infections, antibody testing is not in much clinical diagnostic value, and it can't confirm this is a current episode or reactivation, or this is a primary ongoing infection. So the other thing is, with expansion of newly diagnostics, this next generation sequencing is coming up. Now, next generation sequencing, they can sequence in any samples and go into metagenomic identification. So they can detect any microbial genome in human tissues and samples. But we have to interpret these tests very carefully, because sometimes contaminant or latent infections, co-infections, those viral genomes can be detected in these samples, and might be your treatment might go into a different misleading pathway. So interpretation of this NGS results is very important, and you have to interpret these things very carefully with the clinical findings. Because some private laboratories now offered as a diagnostic test as a NGS also, and sometimes you can see very unusual, very funny bacteria and antibiotic sensitivity patterns. There's reports, but be very careful of interpret these infections, especially when it's come to bacteria and fungi, which can be contaminants or maybe commensals in our body. Usually viruses are considered as pathogens, but sometimes even latent viral genomes can be detected by these NGS methods, and maybe your treatment pathway goes on a wrong direction because of this NGS finding. So interpretation is very carefully has to be done. So moving on to diagnostic part, the proper collection and transport of these samples are very important, and it has direct effect on the quality of the results. So if you get a good quality results, you have to know what to collect, when to collect, how to collect it, and how to send these samples into the laboratory. If you can answer these four questions, then you can select and send high quality samples into the laboratory. Then you will get the high quality, the perfect results from the laboratory as well. So what to collect? It's depending on the clinical disease. So if it is a localized infection, you have to collect the sample from that site. If it is a systemic infection, you can take the sample from the blood. Like example, if patient is present with respiratory tract infection, you have to collect the sample from the respiratory tract. If it is a systemic infection like dengue, chikungunya, or varicella, you can take the sample from the blood. And also, knowledge of the disease and pathogenesis is very important to collect the sample. Like in most respiratory viruses do not go into the bloodstream. So collection of blood sample for respiratory pathogen detection is no value. But sometimes, like hepatitis thing, the liver is affected, but you can't access the sample, get the sample from the liver. But this hepatitis viruses are circulating in the blood, so you can take the blood sample for diagnosis of hepatitis virus. Same thing, site of the infection might be accessible, might be even not accessible. Like example, like if you detect wart-like thing, you have to take the sample from biopsy from that wart-like lesion, not from the blood, because that HPV virus is not going to the bloodstream. And also sometimes you need to collect multiple samples or repeated samples, especially excreting viruses. Viral excretion might not be static. There may be variation of the viral excretion. So you have to collect multiple samples to exclude certain viral infections. So specimens, usually if you go by syndromic approach, you can select the breath sample. For acute febrile illnesses, if you're suspecting hepatitis, chronic viral infections or reactivation of viral infections, fever with rash like thing, the blood is the best sample. If it is you're suspecting CNS infection, CSF will be the blood sample, but sometimes because of contraindications and patient's consent, you might not be accessible. So maybe you can take blood sample with that. You can sometimes it give the evidence of certain viral infection. Certain infections like associated features, like if it is patient present with blister like rash or ulcers, you can take those samples and it will give indirect evidence that maybe this viral infection can cause this CNS infection. If you are suspecting like enterovirus or something, you can collect the throat swabs and stools as well. So if it is a gastroenteritis infection or acute faxis paralysis, the stool is the best sample. If it is eye infections, you can collect conjunctival swabs. And if it is internal eye infections like retinitis, the vitreous fluid will be the best sample. Then for respiratory infection, you can take variety of respiratory secretions. Congenital infections, you can collect urine and blood. For ulcers, you can take the swabs. Blisters, you can take blister fluids, and or if you're suspecting anything with biopsies, you can take antemortem or postmortem for viral diagnosis. So when to collect? If we are going for a viral targets like genome, PCR, antigen detection, you have to collect the sample within first to 5 days, 5 to 7 days of illness in the acute viral infections. After that, the detection ability of the virus from your sample is very less. But there are exceptions. If it is a chronic viral infection, at any time you can detect these viral genomes or antigen from the patient's blood. The other thing is antigen detection, antibody detection. The IgM antibodies you can detect usually after day 5 of the acute illness, and IgG usually after day 7 or 8. But if single IgG cannot exclude the acute infection. So I will go through how to collect these samples. This is very important to instruct your junior people to how to collect and send the correct sample. So if you are requesting for blood for antibody detection, or sometimes for antigen detections like hepatitis B or dengue NS1, you collect 3 to 5 ml of venous blood. This is into a sterile, dry screw cap tube. With or without anticoagulant is okay, and ask them to keep around 30 minutes in the room temperature, and you can transport this one into the laboratory in a room temperature. But if you think there's a delay of transporting, sometimes these virology laboratories may not be available in your institution. You have to transport for separate place. You can keep this at +4, the door of the refrigerator, for 24 to 48 hours. If you think there's a further delay, maybe sometimes in some institutions, they come into a Colombo other place once a week, like, if further delays, you can ask the lab to separate the serum and you can store the serum part at 4 degrees so for 72 hours or maybe -20 for long term. That is very important. If you separate the serum, the sample quality might be very high. Then more chance of getting good results. The other thing is, if you are not separate the serum, do not freeze the sample. Keep it at +4 for 24 to 48 hours, but don't keep this antibody testing or antigen testing samples more than 72 hours in +4, you will not get good results on these samples. They might be decomposed, and antibodies might also not detected in these samples. And also, if it is samples are contaminated, decomposed, or hemolyzed, these samples are not recommended for virology antigen detection or antibody detection test. It's better if you can take another sample instead of these immunized samples. So please arrange your transport system and the collection of the sample timing with that. Like if you keep your sample maybe in refrigerator for more than 4 to 5 days, there will be no value testing on those samples. So if you are going for send for blood for virus genomic samples, for blood, you have to collect 3 to 5 ml venous blood into sterile, dry, screw cap EDTA tube, because we preferred plasma over serum for molecular testing. These samples should be sent soon as possible to the laboratory. If delay, you can keep at +4. For RNA viruses, we recommended only 6 hours, and DNA viruses for 48 hours. Beyond that, if you store these samples in +4, the RNA or DNA might be degraded, and the ability of getting proper results is less. So please remember that. Other thing is, do not freeze these samples, because freeze and thawing will reduce the viral load and the viral genome in the samples, and you might get the negative results. And if you think it's delay in sending these samples into the lab, you can ask your own microbiology laboratory to separate the plasma, and you can keep the plasma in -20 or -70, and you can transport at once. So please instruct the transport people to do it. The same thing also, hemolyzed and contaminated samples, not suitable for molecular detection as well. CSF, usually we use CSF for PCR testing. We usually recommend to collect the last sample for this one, because of availability of virology testing. Now it's become for 5th samples. Usually you collect one for sugar, protein, cells, and bacteriology, and collect another one for virology. Usually we preferred sterile screw cap plastic bottle or tube, and you can store this one 4 degrees, same as blood, until transport, and you have to transport this one in ice. But sometimes, like arboviral detections, you can't detect viral genome, especially for JE or measles in CSF. So you can use this CSF sample for antibody detection. So you can send the same sample with +4. So the laboratory can do both test or molecular testing plus antibody detection testing as well. Then sometimes patients can be present with ulcerative disease or any lesions. Then you can take the surface swab from these ones, or from the surface, ulcers, oral mucosa, ear, then from the urethra, cervix, conjunctiva. First, you have to clean the surface with normal saline or distilled water. Do not use any antiseptic. Then you take the swab and just rub the swab several times over the lesion, and put this swab into a viral transport medium or nucleic acid stabilizing medium. I think most of now you are familiar with these ones after COVID outbreak, and you can send to the sample. Same thing is applicable. You have to keep in +4, do not freeze, and you have to transport this one as soon as possible into the laboratory with ice. Now these commercial transport mediums and swabs are available. So these might be stable up to 48 hours even in room temperature. And sometimes some viral infections can present as a blister lesions. So you can take the blister fluid. You can clean the blisters with normal saline and distilled water, and you can aspirate the fluid using sterile needle like insulin needle, and you can put this aspirated fluid into the viral transport medium. Maybe you can aspirate 2 to 3 times the transport medium and push everything into the transport medium. Same transport conditions apply for this one also. The same thing can be used for vitreous fluid and pericardial aspiration as well. Then another important section is this respiratory viral specimen collection. So there are a variety of respiratory viruses can cause respiratory symptoms. So main thing is we can collect nasopharyngeal aspirate and swabs. It's also nasal and throat swabs, tracheal aspirates. If you are doing bronchoscopy, you can take bronchoalveolar lavage. And if it is a postmortem samples, you can take true cut biopsies or punch biopsies. And sometimes you can collect oral fluid also for measles and rubella detection. The same thing, you have to collect the sample into a viral transport medium and you have to send as soon as possible with ice to the laboratory. So the best sample for nasopharyngeal sample collection is nasopharyngeal aspirate. For this one, you need this nasopharyngeal aspirator. You have to collect, you have to add viral transport medium into this aspirator. You can put the one end into the nasopharynx, the other end you can collect into the sucker or large bore needle syringe, and you can suck from here. Then all the nasal secretions with cells will be collected into this one. Then you can remove this part and you can put the cap and send it to the laboratory. This is the best sample for correcting respiratory thing, especially from the children. But time to time, this device is not available in market. So therefore, we have to go for nasopharyngeal swabs and oropharyngeal swabs. So for nasopharyngeal swab collection, we have to use this device, the nasopharyngeal swab, which has a very thin shaft and a thin elongated swab and the viral transport medium. So you have to get the sample, respiratory sample from the nasopharynx, because most of the respiratory viruses are infect the column epithelium. So you have to reach the column epithelium, which is in the nasopharynx, and you have to collect the sample. Otherwise, if you collect from the anterior part, the column, there may be only the squamous cells, which is less infected by the virus. So if you get a good results, you have to reach the nasopharynx and get the nasopharyngeal swab. Same thing for respiratory samples, throat swab, you have to get the posterior part of the throat using throat swab and collect the samples into a viral transport medium. I think you all are very familiar with collection of respiratory samples after COVID outbreak. So you have to put this swab into the viral transport medium, then you have to seal it and you have to send this sample into the laboratory. The other thing is sample you can collect is for genomic detection, is like cytomegalovirus or BK PCR, especially in transplant patients. You can collect urine samples. Usually for urine samples, we have to collect 10 to 15 ml of midstream urine. No need to add viral transport medium. We prefer sterile screw cap bottle into a leak-proof container. Usually we ask to collect into a urine culture bottles, disposable ones, and you can send this one into the laboratory with ice as soon as possible. If delay, you can keep it in the refrigerator, but same thing applied, do not freeze these samples. Then you have to, for post-mortem samples usually, for genomic detection or antigen detection, we can take biopsies, or even if you go for like colonoscopy or colonoscopy or endoscopy, you suspected like cytomegaloviral lesions or something, you can collect the biopsy samples as well. We need a small piece of tissue, collect it into a viral transport medium. But if this one collected into a formaldehyde, we cannot use this one for viral antigen detection or molecular testing. So please send these samples in a viral transport medium. If viral transport medium is not available, you can add little bit of a sterile water or normal saline or even alcohol, small thing, moist this sample and put it into a sterile container and send it. And please to remember, especially when you are doing post-mortem sensing, you need to collect samples from the separate set from each body, because if we come across during COVID also, sometimes if you use the same punch biopsy too, because even this is a death patient, so nobody cared about the infection control thing. So if you use the same one, you can get the false positivity maybe in the second one. Like same thing, you can use lung tissues for respiratory viruses, then the heart samples for enterovirus isolation. These are post-mortem samples. Especially they are now antemortem samples very rarely used for viral diagnosis. And if you're suspecting gastroenteritis infections, you have to collect stool samples. And the other thing is this acute paralysis surveillance for poliovirus. You have to collect the sample from the early stage of the illness. You have to collect into a clean screw cap wide mouth bottle, usually 3 to 5 grams of stool. So don't send large quantities of stools because it's difficult to handle those samples in the laboratory. No need to add viral transport medium or any other medium. You can store and transport these samples to the laboratory. When you come to rabies, now the corneal smears and nuchal biopsies are not encouraged. We can do blood and CSF antibodies from the patient. And other thing is, you can, if you do a lumbar puncture, we can do the CSF for rabies PCR. And other thing is, we have to collect pool saliva for rabies RNA detection. For this pool salivas, you have to collect the sample, 2 to 3 samples, maybe two hours apart from the patient and collect into a same transport medium. And also, you know, the after suspected rabies or animal bite, post-mortem is mandatory and laboratory test is mandatory. So this is mainly for judicial medical side. So for you all to only to request the post-mortem and ask them to send the sample. Usually we ask the whole brain, and you have to send this one only to the Medical Research Institute. If you're suspecting any other pathology, you can cut and examine and take samples for histopathology, and rest of the brain can be packed and sent to Medical Research Institute. If you're suspecting congenital infections, especially in pediatric populations, you can collect dead fetal tissues, neonatal blood, maternal blood, then the neonates' urine and blood for molecular and serological assays as well. When you are transporting the specimens, it's very important to properly fill the request form, because patient's name, age, the bed ticket number, clinic number, and the ward is very important. Other thing is we need the hospital in full, because these samples are going into different laboratories. Sometimes we get confusion where to send these samples, especially if you like write THK, it can be Teaching Hospital Kurunagala, Teaching Hospital Kegol, or in previously Teaching Hospital Kandy, even Teaching Hospital Karapitiya. So we have some difficulties where to send these samples. And please add the relevant history, date of the onset of the illness, date of collection, duration of the illness, and time of the sample collection, any vaccination history. Then we can interpret the results and give you a correct interpretation for these samples for your correct management. And also ask and supervise your junior staff to how to label the specimen as well, because the label also should contain name, the identification number, then the ward and clinic and hospital in full, and test request required, and the sample collection data as well. Please supervise this. Otherwise, it's very difficult to interpret these results. Also, sometimes send these results into a sender, especially these tests are going into outstation or different laboratory, not in your institution. So they might be in trouble to contact you and get other details. Especially this is very unique to MRI because they get all over the place. But if it is you are sending peripheral laboratory, maybe they know the draining area, they know which ward or something, they with the seal or something, they can contact and get the further details. When you are transporting, usually please adhere into the transport guideline. Now, Ministry of Health will be issuing the transport guidelines as well. Usually, we ask these containers put into a plastic or polythene bag, and then you can put it out a container. You can pack ice between secondary and tertiary containers. If you are highly infectious sample like COVID or rabies or any suspected hemorrhagic fever, mpox, maybe you have to follow the guidelines and put this one in a triple package like we did in COVID and send into the laboratory. And with this, you have to send details outside the your package, because otherwise we can't reach the sample details before we are opening the container. When it's come to availability of virological diagnostics in Sri Lanka, the MRI virology department doing diagnostics, reference and surveillance. Then we have three virology laboratories, peripheral regional laboratories, one in National Hospital Kandy, National Hospital Galle and Teaching Hospital Anuradhapura. The National Hospital Kandy and National Hospital Galle has a very similar diagnostic range compared to MRI as well, without in few surveillance and reference samples thing. Other tests are also available. TH Anuradhapura also has a good diagnostic range. Then other laboratory in Western Province is National Cancer Institute Maharagama as a virology laboratory. It also has has wide variety of virology diagnostics, but mainly focusing on immunocompromised and cancer patients. Then microbiology labs in National Institute of Infectious Disease, Teaching Hospital Ragama, Teaching Hospital Batiklo and Teaching Hospital Jaffna is doing limited number of serology and molecular testing. And also in the private sector, most private sector laboratories doing both molecule and serology testing. And some universities provide specialized molecular testing as well, like Javadhanapura University, then Karapitiya University Medical Faculty, and also Teaching Hospital Peradeniya, the medical faculty. Peradeniya also doing some lab test as well. So if your transport is drained, your hospital ambulance system or other transport system, you can select the closest distance with the availability of testing. So what we usually do is, like I was previously in Kandy, we take the area of that area, like in National Hospital Galle, they can drain into that place as well. Then the North Central Province, they can go into Teaching Hospital Anuradhapura, then rest of can drain into Medical Research Institute. But the problem, sometimes we do these tests as individual test. Like example, if you are doing influenza test, so we can do only the influenza like thing. Or sometimes there's availability of syndromic panels as well, like central nervous system, respiratory panel, gastrointestinal panel, then some tropical febrile illness panel or STD panel like this. But the thing is, these panel tests are very expensive, so we have to go by case basis on to going for these tests. There are constraints when we are doing. The most these virology test we are doing as a batch test, like PCRs and ELISAs. So there may be a fixed date to do this. But now these peripheral virology laboratories, the hospital-based ones, they have random access automated serology analyzers. So you can get reports within same day. So it will be very fast. Another thing is, so these tests are sometimes very expensive because we have to run positive and negative controls as well. So it will add the cost for these tests as thing. The other thing is after this 2003, we are having some problems with the supply chain issues. So most of these labs are time to time running out of reagents. The other thing is uh, now because of global trends, some suppliers are not very keen on supplying these reagents because our market is very small, so they don't get much profit, so they don't like to supply these things. Other thing is some of these tests are, most of these virology tests are not registered at NMRA, and these agents are not very happy to do it because they sell only 1 or 2 diagnostic kits for whole country per year, so they were not very much bothered about getting registration and go that strenuous procedure. So we were working on this one, how to get these small quantities into this one. Otherwise, we were running out of these supply chain issues very recently, because after this 22, 23, this problem has occurred. Previously, there was a good supply and chain was going on, but now we are sometimes running out of these reagents. Then that's, I think, all for all viral diagnosis. Do you have any questions? Or shall I continue to special areas?
I think you can continue, Dr. Muthugala. We'll
Right.
entertain the question at the end of the session.
Right. So please utilize available virology testing. Just make liaise with the closest your virology laboratory, then they can help. And always contact with your microbiology laboratory, then they can arrange those transport and everything into the other laboratory. Then it will be more supervised and they will send the correct way. Because otherwise, when I was also in Kandy, that's why I started most of the tests there, because sending the sample to other places, it's very difficult. Now these days you can't order ambulance for sending transport purposes as well. So we have to keep these in the other place, the somewhere, then they not, these ambulance people don't collect those samples. Sometimes they take only the sample, not the request form. The cold chain problems are there, and there's missing samples. So many problems. So it's better if you can divert the samples into the closest laboratory and get the results. And even the closest laboratory can give and feedback even over the phone if you have a good connection with them. Then moving on to 2 important areas, like dengue is bit complicated because you have a primary infection, primary dengue and secondary dengue. The important thing you has to know is like the primary dengue act as acute viral infections where you see the virus maybe can detected up to 7 to 8 days. The NS1 antigen, then the IgM antibodies, which will last around 50 to 60 days, and IgG antibodies lifelong. But if you happen in the secondary infection, what's happened? In the first day, even early phase of the infection, you can get rapid IgG response, very rapid, and then the NS1 antigen will be the same and very minor IgM response. The important thing is within the secondary dengue, early phase, there will be NS1 antigen in the blood as same IgG antibodies in the blood. Sometimes in the blood, this IgG antibodies and NS1 will form complexes and it might not be detected in the NS1 antigen test. So the sensitivity of NS1 antigen test in secondary dengue is around 40 to 60%. So please remember that negative NS1 results cannot exclude secondary dengue. So that's why NS1 antigen usually detected up to 5 days, but it can be even detected up to 10 days. So sensitivity is primary infection, 90 to 95% up to day 3, 80 to 85% up to day 5, and then after that gradually reduces. In the secondary dengue, the early phase also, the sensitivity is less. It's around 60 to 70%, sometimes even can be 40% because of this antibody response. And this is a highly specific says almost 98% specificity is there. Sometimes there may be cross-reactive with other cross-flaviviruses like Zika, or sometimes in sepsis-like conditions, you can get false positive results. Then dengue antibodies, the other thing is after day 5 of the illness, antibodies can be detected. Then IgM positivity indicates only the evidence of recent infection. As I think you can remember that graph, IgM antibodies can be present up to 3 to 4 months following acute infection. This is applicable for all viral infections. The other thing is there may be cross-reactivity among other flaviviruses as well. And during secondary infection, IgM surge is very low, so can be negative as well. Then detection of IgG antibodies is give only the past infection or past vaccination. So you need to take samples to 7 to 10 days apart, and you can has to show the fourfold rise of or decrease of antibodies. For dengue, it's better if you can go for a NS1, IgM and IgG combined test, which is now available, that give the sensitivity, the detection diagnostic ability to 90 to 93%. And if it is NS1 negative but IgG positive, please suspect secondary dengue. And if you need, the confirmatory test is by PCR or IgG levels. And dengue PCR is 99% sensitive in both primary and secondary dengue. The message is, in secondary dengue, NS1 negativity cannot exclude the dengue, and also IgM dengue can be last up to 3 to 4 months, even any viral infection. So if you present with another infection and you check for this one, IgM positivity may be there. So please interpret this one very carefully. Other common one, problematic one is the influenza. Usually best test is the PCR test. The sensitivity is 98%. And there are influenza rapid tests are available, but the problem is compared to this COVID antigen test, which is sensitivity is 80 to 85, the influenza rapid test sensitivity is 40 to 60%. So negative rapid antigen test cannot exclude influenza viral infection. So always do not wait for lab confirmation in high-risk patients. Please go for treatment in high-risk and severe patients for influenza with oseltamivir without waiting for laboratory confirmation. And please remember, negative rapid antigen test in influenza cannot exclude influenza viral infection. So thank you. You have any questions?
There are a few questions. First one, sometimes VTM is not available. Then do you suggest any alternative?
Usually VTM, the time to time, there's a problem actually. If it is VTM is not available, the other thing is we can use it, put this one, the sob into a 70% alcohol or a small amount of sterile water, but the results might not be very accurate.
Okay. So the next one, what are the instances that a pooled sample testing is advised in virology? Can we apply in any sample type or disease where a single sample might not be positive? So what are the
Then,
instances that a pooled sample testing is advised in virology?
yeah, one instance is one pool sample we are using during like large pandemics or outbreak situation. We need to screen large number of samples in a large number of population. Uh, we did for COVID, we used the pooled sample because laboratory capacity is less and the resources are less. We can do the pool testing. If it is a pool is positive, we have to open up the pool and do individual testing. So this is recommended only during large number of screening testing and also when resource poor setting. The other pool testing we recommend is same patient, you can get the pool testing. One instance is like if you're suspecting congenital herpes simplex virus infection from child born into a mother suspecting herpes simplex, you can collect swabs from eye, groins, nose, rectum and put it into a one transport medium.
Okay, thank
And
you.
also for rabies, if you're suspecting a rabies patient, we need that pool saliva sample because these viral excretions sometimes time to time vary. So you can take the saliva sample within 2 to 3 hours apart and collect it into a same transport medium.
Okay. So the next question is, what is the usefulness of CT value in chikungunya PCR?
There's actually no value because the viral load, maybe later there might be research comes with high viral load and this one. But CT value, usually we use this quantification technique for chronic viral infections like HIV, hepatitis B, hepatitis C to see the treatment response. Whether your treatment response is after certain time period, whether the viral load get reduced, then it will give your treatment response is good. The other thing is CT value and quantification we use, especially these transplant related infections like cytomegalovirus, BK virus, Epstein-Barr virus things. Usually we all are infected with these viruses. Time to time we can excrete or there may be viremia. But in these immunocompromised patients, if a viral load is very high, then you can suspect this virus is start aggressive multiplication in these patients. But for other like acute viral infections like dengue, respiratory viral infection, chikungunya things, CT value is not much clinical value because it's only a qualitative test which need to say it's positive or negative. But sometimes if it is low CT value, you can say this may be a late phase of infection or it can be even early phase of infection. That is the only interpretation we can say.
The next one is a dengue combo test available in private sector.
Yes, it's available. Even time to time, it's available in government sector as well. So what I recommend is if you if all people can, this request form contain the day of the illness, then if lab can decide, not in private sector, because private sector, they have to charge separately, but in government sector, if you write the day, then lab can go for all testing. Like if less than 3 days, they can go for NS1, more than 7 days, they can go for IgM, in between, you can go for combo testing. Even for private test sector, if you are ordering, like at a middle gray period, you can order for combo test.
Okay, so second, I lost my screen. Hello.
Hello.
Yeah. 1 second, I lost my screen. I got a call and then I lost everything. 1 second. Yeah. The next question is a fourfold decrease in IgG, is it diagnosed the condition? I don't know,
Yes.
maybe increase, so
No,
they says,
both,
but
both. If it is
yeah.
fourfold rise or fourfold decrease, it's indicate it is very recent that targeted antibody targeted virus due to that virus. Both. We can use both fourfold increase or decrease 10 to 14 days apart for as a confirmatory test. IgG.
Okay. Yeah, that's all the questions there in the Q&A section. And thank you very much, Dr. Muthugala, for taking trouble and educating us on the new virological diagnostic tools and how to collect the samples and how to send and what are the pitfalls that we encounter and how to counteract everything. So you have made everything very clear. So thank you very much for you. And then on behalf of Sri Lanka College of Internal Medicine, we thank you for your great the contribution, and then thank you the participants for showing your enthusiasm in participating.